Hello, good morning, everybody. Just giving it a moment while I see people still connecting to their audio. I'd like to thank you for joining us, and I'm Stephanie Hendrickson. I am pleased to welcome you to our Palliative Care Education Community of Practice session on providing virtual palliative care in the North. Before we begin, I would like to acknowledge that Sarah is located on the traditional territory of the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. And we do recognize that our speakers and our attendees today are joining from your respective traditional territories as well. Just a little bit of history about our community of practice. It was established in 2015 as a result of our Palliative Care Education Collaborative, which is co-led by, sorry, I have a fire truck going by. It's co-led by SARA, which is the Center for Education and Research on Aging and Health at Lakehead University, and the Northwest Regional Palliative Care Program, which is at St. Joseph's Care Group. And our collaborative has a broad membership of agencies and individuals with mandates related to palliative care education in Northwestern Ontario. So the session today is the first of two being presented by our community of practice, and the topics were chosen based on a survey of our membership. We do typically host two face-to-face sessions each year. So we do one in Thunder Bay and then we do one in the region, and we go back and forth between the East and the West. So we do look forward to, in the future, hopefully continuing that practice. However, for now, we will plan to offer these sessions virtually. And we do hope the information shared today will be useful to you in your role. So just some really quick housekeeping in terms of Zoom and how questions and answers will be handled today. We do ask if you can keep your microphones muted throughout the presentation. You may wish to keep your video off. It will save your bandwidth, but that's up to you. We are asking that all questions be held until the end of all three of our speakers' presentations. However, you can feel free to pop your questions into the chat box as we go along, and we will bring those forward at the end. And if we do have time, we'll of course invite you to come off mute for questions and discussion at the end as well. And just to let you know that after the session, I will be following up with some virtual care resources and copies of the presentations that we're able to share. So with all that being said, I am going to ask Kathryn Mcisak to please introduce our first presenter for today.
Hello, thank you, Stephanie. So I'm Kathryn Mcisak. I am one member of the collaborative for the palliative care education community of practice. Just myself, I work for the Northwest LHIN with home and community care, and I'm the manager of the palliative care program, as well as the palliative pain and symptom management consultation program. And Nikita, I have the wonderful fortune of spending a significant amount of time with, who is our first presenter today. So Nikita Matichuk, nurse practitioner, is a primary care nurse practitioner who has been working as a hospice palliative care nurse practitioner with the Northwest LHIN since the program's inception in 2013. She is also a certified hospice palliative care nurse, LEAP facilitator, and frequent SARA collaborator. Nikita covers a remote catchment area of Northwestern Ontario with a population of 20,000 people, which includes her hometown of Atikokan, where she lives. Nikita provides a palliative approach to chronic disease management, follows patients through their disease trajectory until end of life, and manages expected deaths in the home.
Okay, thanks. You, Nikita. Thanks, Kathryn. You guys can hear me okay?
Yeah.
Okay, perfect. So yeah, for a little bit of background information, as Kathryn mentioned, I did start in this position as a new grad when the program started in 2013, and I provide in-home palliative care to the residents of the Rainy River District until COVID happened and my practice changed to primarily virtual. I know most of us are from this area, but for those who don't know, the Rainy River District is the little light yellow portion down in the bottom of the left bottom of this map. And it runs along the US border. So I live in Atikokan, which you can see there, and was traveling to Fort Frances, I was going to at least Fort Frances twice weekly. It's 150 kilometers from Matichuk to Fort, and then another 90 from there to Rainy River. On average, I spent about 20% of my work week in my car driving, and then at that time I was unavailable to my patients. The next slide. So what exactly is virtual care? Virtual home care is the meaningful communication of a patient's health status and or the implementation of a treatment or intervention needed to support their care. And we do this utilizing phone calls, video conferencing, secure messaging, and or remote monitoring instead of an in-person interaction. So LHIN providers such as myself are using previously existing virtual care technologies, including the video conferencing tools provided through the Ontario Telemedicine Network to support virtually delivered care. Right now, I'm using patient-owned devices to support the care. So people have their own cell phones, tablets, laptop computers. But there was a time a couple of years ago where my program had, I think, 2 iPads, and I was able to loan them out for virtual care. They're old and obsolete now, so I'm no longer using them. I do occasionally use email when requested by patients or family, but at this time, I'm not using any remote monitoring or secure messaging or any symptom assessment apps. So when I mention and talk about virtual care going forwards, I am referencing either phone calls or video conferencing. So the next slide. This change to primarily virtual care is a direct result of the COVID-19 pandemic. Like I said, I did do a little bit of virtual care before this, but COVID is the reason why things have changed. So as the COVID-19 pandemic continues to evolve locally and globally, the transition to virtual care ensures the province's healthcare system is prepared to continue to protect the health and well-being of Ontarians. It is an alternate way of working during the pandemic, and virtual care is expected to support provincial public health self-isolation and social distancing efforts in a way that minimizes disruption to patient care. There have actually been times where I myself have been on self-isolation and have been able to continue working, doing virtual care, which is really awesome. Virtual care supports intake, assessment, monitoring, and treatment of patients with presumed or confirmed COVID-19. So going the other way around, it sort of saves me from having to contact them while still being able to provide excellent care. And it does support the delivery of most home and community care services. The next slide. Although it may be a new concept to many people here, virtual palliative care was actually studied in Canada pre-COVID. And the researchers hypothesized that many aspects of palliative care could either be completed virtually while improving barriers to care, which includes the time constraints for both the patient and the clinician, concerns with distance, and also weather. Weather was a concern for me. Previously, I would make appointments for people, morning comes, snowstorm, right? So then obviously I wouldn't be traveling. They hypothesized that it would provide the same high level of care. And the results showed that participants overwhelmingly agreed or strongly agreed that virtual care worked really well, it was effective, it addressed their needs, and they felt comfortable using it. There was some often initial skepticism on the part of the patients, and I find that too, a little less now that we've been doing this a year, but this always eases after the first visit. So the next slide. So studies have proven that virtual palliative care is effective, feasible, and accepted, but we don't know how it compares to the standard of care doing in-person visit and house calls. There is a large study going on in the US right now that will likely help guide us to whether our current models of virtual care are going to be continued once COVID-19 is ended. I'm not sure if this trial has been affected by the pandemic or not, as it was going on beforehand. But they are comparing, like I said, the standard of care in-person visits versus solely virtual to see if they have all the same health outcomes. And personally, I can see a continued role for virtual care. I do think it works well, and I can see myself moving to more of a hybrid virtual versus in-person model once the pandemic has ended and things sort of go back to normal. The next slide. So the virtual care appointments, there are lots of things that I'm able to do quite well without actually, doing a physical exam and being there in the home. These are the things that the researchers found were particularly effective during virtual care, and I, completely agree. I'm able to provide really good psychosocial support, good patient education. I'm able to provide symptom management, change medications, order new things, whatever I need to do. I can do that all virtually, with no problems. I often make referrals to other services, whether it's nursing, personal support, PT, OT, dietitian, all of that stuff I can do virtually. Having conversations about changes in goals of care, I also go very well virtually. They are a little bit easier if you have a video versus just on the phone. But people are quite accepting of that this is the way things are right now. So even those conversations go well. The physical exam is its only limitation. I'm able to do a visual exam on some things when we do have video, which is very helpful. But I'm not there in person hands-on. Often I'm able to send a nurse to do a specific physical exam if I need it. For the most part, a lot of what I do does not require a physical exam, as I treat the patient's symptoms. Let's say they tell me they have shortness of breath. I'm going to treat the shortness of breath whether or not they have good lung sounds or not. Some things, if I'm thinking it's more of a pulmonary edema, a bit of congestion, I may send a nurse in to check O2 sats and listen for crackles, because that might change my treatment plan. But for the most part, it doesn't require an exam. Pain is another good example of that. If a patient tells me they have pain, I'm going to treat it, whether or not I've laid hands on them or not. The next slide. So there are some, big strengths, I think, about virtual care. People are generally quite receptive to it. They also want to limit their contact with other people. In normal times, I'm going from house to house to house, which is, a possible mode of transmission. I could be the one to bring COVID to them. So generally, people are pretty receptive to doing things virtually. I find that we do have a real, genuine connection. We'll go through in the case studies, but there are people that I have never actually met doing complete, palliative transition to end-of-life care, and it goes well. Virtual care allows me to have much more frequent contact with patients. I have opened up 20% of my time to be available to people. So I am more available for quick, urgent, return of phone calls now than I was before. Virtual care is pretty convenient. I mean, you don't have to go anywhere. I don't have to worry about, the weather, starting my car. I mean, patients are already at home, so home visits are pretty convenient for them, but virtual care is convenient as well. We're also able to connect caregivers near and far. So on one video call, just like all of us right now are, all over the region, we can do that with virtual care as well and connect with people anywhere and make them feel like they are, just as engaged as if they were in the house. And finally, I've mentioned it again, efficient use of clinician time. I've really been able to increase the amount of patients I've, been able to see and provide care for because I'm using virtual care. The next slide. Having said all of that, of course, there are some difficulties. This isn't perfect. Consumer education being one. Some people are, most of us have a smartphone now, but not everybody uses it to that capacity. Some people, are completely right on board, and others, not so much with the video component, at least. Technology limits, definitely a problem. You need a fair internet connection, or at least a cell signal to get good audio video quality. Sometimes I find with the video conferencing software, you'll have a good video with the audio lags. Sometimes I'll actually do sort of a combination of both. I'll keep the video, we'll both mute ourselves, and then we'll be on the phone. That's a good workaround sometimes. Medication lists can be difficult over the phone. In the home, I grab all the medications, I physically look at them, I'll check refills, I'll make sure that all the lists match. I'll look for random pills that don't belong anymore. So not being there, that is a bit more difficult. I encourage patients to bring all of the stuff and then read it to me if they have to spell it out. That works, but it is, that's one of the things that's probably easier in person. If the patient has significant cognitive impairment, of course, that's going to be a trouble, especially if there's no one in the home to help facilitate virtual care. Speech or hearing difficulties can be difficult if people are hard of hearing on the phone or having trouble speaking and I can't hear them. When there's no other healthcare providers in the home, things can get difficult because, like I mentioned, I often have the nurses go and fill in the gaps that I'm not able to do in person. It's also really helpful to have, a partner there who's able to really describe what's happening on the phone if I don't have a visual. And then finally, actually having that visual, laying eyes on the patient does help with prognostication to say if someone's cachectic or not. You can really see a lot just by looking at someone. So yeah, that can be one of the issues with doing telephone calls. Okay, the next slide. Okay, so to actually do this, primarily, we are using OTN. Lots of people are using Zoom. Of course, we're using Zoom right now. I know many of my healthcare partners use Zoom as well. At the LHIN, we use MS Teams to talk to each other. So that's another one that I'm familiar with. If you're planning on doing virtual care using video conferencing, learn your program, try and get it set up so that where buttons are located, especially on the patient side, because quite often people will come on with just their microphone and then I'll have to say, okay, well, you're looking for the button that looks like this and it's in this area. So I find that, learn your software is important. Set yourself up in a quiet space with good lighting and an appropriate background. So this is my bedroom. This is where I have set myself up in my office. I do have a large window beside me that does that. So I do need to keep it closed to have good lighting. I have a neutral background. Sometimes if some things are available, you can do a virtual background on Zoom and on MS Teams, but OTN doesn't have that capability. You, as the provider, want to use an in-home wired or wireless network instead of the cell network. If you have the best internet possible, it does make things easier because quite possibly the patient will be on a cellular network and their bandwidth might not be as good. You want to use a camera with good high resolution so that people can actually see you. For setup, I do it two ways. I will make an initial phone call. You have to get the patient's or family's email address in order to be able to send this out. So I email them instructions depending on how confident they are with it. Sometimes I will call first to walk them through the setup. Other times, if I think things are going to be okay, just based on the confidence of the patient or family member, I'll just wait and sign on. And if the patient's, 5 or so minutes late for my appointment, then I'll call to set them up. That works either way and sort of whatever works best for you. The next slide. So when you first meet with people during your initial appointment, this may be the first time you've ever actually seen this person. This may be an appointment that the person, but have switched to virtual care. I think it's really important to dress the part of a professional when I'm doing my virtual care appointments. I look just like this. I wear a scrub top. Sometimes I have my hair up, but it does show that I, am who I say I am. I start with, a comprehensive introduction, explain my role. I tell people that I'm in a private location, that I'm in my bedroom, I have the door closed. Working from home, though, I do have pets, children, stuff happening, loud noise outside. I do mention to people when my kids are in the house or when they're not. Sometimes, even though my door is closed, the kids will just come right in. Patients are generally pretty receptive to that. They understand that we're also working from home. And, I think people actually find it makes a good connection. When my cat jumps up on me, I tend to actually, oh, it's my cat. And then I'll show them. And yeah, people think that's really cute. So then I will also address any concerns that the patient may have about privacy and security of the technology, but people don't really have a lot of concerns, at least in my patient practice. That doesn't really come up all that often, but I do mention it. So the next slide. So back a few slides ago, I did talk about the aspects of palliative care that can be accomplished well in a virtual care setting. So just to remind you, psychosocial support, patient education, symptom management, change of medications, referrals, goals of care. These things really do make up the majority of my initial assessment with patients. This is all of the stuff I go through during an initial assessment with every patient, whether it's virtual or in person. And like I said, these things really do lend themselves quite well to be done virtually. The next slide. Okay, perfect. So I do want to go through a couple of case studies here and actually go through how this all worked. So I'll get started here with my first one. Was a woman in her 40s who had metastatic breast cancer. My first contact was made by phone. I called once I got the referral. I introduced myself. We discussed virtual care options, and she consented to do virtual care. And then she provided me with her email address, which of course I need to send her a link to the video. So our initial visit was done over OTN. I went through everything on that previous slide. These are generally an hour to an hour and a half visits, depending on the patient and how much they have to say. I did make medication changes at that time for pain and symptom management. I also did a referral to nursing for palliative monitoring because they hadn't been put in place yet. Our second visit was actually later that very same day. Unfortunately, the patient had developed some vomiting after she had the initial dose of oral morphine that I had prescribed. And because our initial visit was virtual instead of in person, I was readily available to answer the phone and to adjust her treatment plan. It's quite possible that prior to COVID-19, I would have been in my car when she called to say that the hydromorphone had caused nausea, and I wouldn't have been able to readily reply and probably wouldn't have returned her call until the next day. So that's one of the things, like I mentioned, being more available, having good use of clinician time. Our third visit was the next day. I was able to speak with the nurse. She was there in person, which was awesome. She was able to fill in the portions of the physical exam that I had missed because I wasn't able to complete those virtually. After that, we had visits 4, 5, and 6 done once a day as daily phone conversations. I was able to make adjustments to her pain and symptom management medications, which worked well for those few days. But unfortunately, visit number 7 was actually quite the crisis. So at this point, the patient's family had called me because she was experiencing quite intractable vomiting. And so we were on the phone at first, but we did switch to video conferencing. So I was able to physically see what was going on. And this patient was on subcutaneous medications, but on the video, I was able to teach the family member who was there how to make changes to the dosing so that she was going to get a better treatment plan. And since I was able to actually see the family, see the medication, see what she was doing, I was able to do this successfully and was 100% confident that she was able to perform this task correctly. The nurses always draw up, 24 hours of medications to last until their next dose. So she did have some on hand, but because I made changes, the family did have to actually draw up more metoclopramide, and it went quite well. The next few visits, we were able to switch back and do them all over the phone. And thankfully, the patient's symptoms were quite better managed at that point. Visit 12, though, was done on video again, as I did complete a MAID assessment for her. I have done MAID assessments over the phone, but it's not ideal. That's one thing that, you want to have visual if you can. It's much preferred, but it is possible to do them over the phone as well. Visits 13 through 17 all occurred over the phone over a 5-day period where symptom management continued. And then finally, visit 18 was actually our first and only in-person visit. This whole situation was quite sad, but unfortunately the patient had declined really quickly overnight one night and was admitted to the hospital with a PPS of 10%. Thankfully, everything came together and we were able to provide an expedited MAID for her. So although her original plan was to have MAID in her home, and we ended up doing it at the hospital, which wasn't her preferred location, but she still was able to have her chosen manner of death and was able to have her chosen people present. So it was still kind of a win. She got most of what she had hoped for. And then finally, my 19th and final visit was a bereavement phone call that I made to the family a week after the patient's passing. And that's a standard of practice that I do as one bereavement phone call. So yeah, as you can see, I saw this patient a lot, really from my initial contact to her bereavement visit. She was on my caseload for a total of 24 days, and she received 19 specialized palliative care nurse practitioner visits during that time. She got a lot of really good care. And during my bereavement visit with the family, they said they were very satisfied with the care that they had received. I think if some of this had been done in person, like I mentioned, I would not have been as available to get these phone calls, to do all of these daily things. So I'm really happy with how this case went, given that she was so symptomatic and needed lots of intervention, that I was able to provide that for her. We'll go to the next slide for case number 2. So similar, again, my first contact was made by the phone. I called, I introduced myself, we discussed virtual care options. The patient consented to virtual care, but she chose to do our first visit over the phone. So I called, completed my initial visit over the phone, and everything was quite similar to the other case. I made some medication changes for pain and symptom management. I was also able to do a referral to the care coordinator to do our EDITH protocol. At this point, this patient's PPS was 40%, so she, was kind of transitional. But she was okay at that day. So our second visit was also done over the phone, but at this time, the patient's daughter had arrived. She was down east and had driven up to be with her mom. So she was there, and we were able to set up video conferencing for subsequent visits, which I like. I really prefer to be able to lay eyes on patients when I can. So visit number 3, I was able to do that. We had a good video conference. We talked about her current functional status, her symptoms. We went over a few things again, because the daughter wasn't there during the initial visit. And at this point, actually, I did not need to make any changes to her treatment plan because things were going well. So we scheduled another video conference for a week later. So we did that. Again, things were pretty stable, didn't need to make any changes, and we scheduled follow-up for the next week. A few days later, though, at the end of that week, I did get an email notification that the patient was seen in the emergency room the previous night. It's really nice that our system is set up like that. So I called her daughter to follow up, find out what happened. It turns out that her biliary drainage tube had become blocked. At that point, it had been in situ for about 3 months. They were able to reestablish the patency in the ER, but the medical team there had told the patient that the tube was starting to break down and it was likely to continue to function poorly unless it was replaced. These tubes only have about a 3-month life before they need to be replaced. And unfortunately, that procedure needed to be done in Thunder Bay. So the plan at this point was to take some time and discuss whether or not a transfer to Thunder Bay was in the patient's best interest, given that, you know, her PPS, functional status, and all of that stuff. So we left it for the day. I did call again the next day, and unfortunately the patient's condition did continue to deteriorate. They decided to pursue end-of-life care at home and not to transfer her out to Thunder Bay. So I was able to arrange for a same-day nursing visit. So then later when the nurse was there and I called back, we had started the end-of-life pain and symptom management medications subcutaneously, and things were going pretty well. The next day, we were able to connect over video. At that point, the patient's PPS was 30%, but she was able to fully participate in the conversation, which was excellent. So we made a good treatment plan for end-of-life care and for follow-up. The next couple of days, I called daily to check in and make sure that pain and symptom management was going well. I did any adjustments to the medications that I needed to do. And then on the third day, she actually ended up passing away. So for this patient, from my initial contact to the bereavement visit, she was on my caseload for a total of 29 days, and she received 12 specialist palliative nurse practitioner visits during that time. And again, when I called for a bereavement visit, the family was very satisfied with the care the patient they had received. And actually this family sent me a bouquet of flowers afterwards, which was very thoughtful. We'll go to the next slide. This one is not my favorite case, and that's why I wanted to bring it up, to say that this happens. So this lady, an 80s female with dementia and frailty, was someone I only had phone contact with, and very, very briefly. I received an urgent referral from a family physician stating that the PPS was 10%, so very urgent. At my initial contact, I was able to complete the most important parts of my intake assessment, again, over the phone. We talked about symptom management, discussed the Edith protocol. The palliative symptom management kit and nursing orders were done urgently, and I requested a same-day nursing visit, and then asked the nurse to call me after her visit that day. The nurse actually ended up calling me the next day. During her initial visit, the patient refused to have the sub-Q line inserted or any personal care provided. I guess she seemed quite comfortable when she was not being disturbed, so the family and the nurse decided to just leave her be and see how things went the next day. So my third and final visit was the next day. The nurse called me to let me know that she had passed away. It turns out that she didn't require any pain and symptom management medications, and things, I guess, went well. These types of cases really aren't my favorite. I like to have more contact with the family, but they do come up occasionally. I mention it today to highlight that this situation happens. And although I only had one quick contact with the patient's family, this patient still received high quality palliative care and was able to die in her preferred location. The next slide is my fourth and final case study. So this one has sort of an interesting twist. This patient of mine was an 80s male with Parkinson's disease. He was referred to me at a PPS of 40% to facilitate an expected death in the home. And he was on my caseload for a longer amount of time, 3 months, and things had remained fairly stable during that time. We sort of had a combination of an initial video conference and then phone calls going forward. Near the end, the patient aspirated and became acutely unwell. We talked about his goals of care. They were to do palliative pain and symptom management and remain at home for an expected death. He did not want to have any antibiotics. But unfortunately, this happened at the absolute worst possible time. This patient's community was experiencing a COVID-19 outbreak at the time, and many of our staff, nursing staff, personal support, they had an exposure and they were all being isolated. So I was not able to provide any nursing support for this person. They did receive a little bit of personal care, but that also meant that I was not able to provide a nurse to do the pronouncement of death. So thankfully, he didn't actually experience any symptoms and he didn't require any medications for symptom management. We had talked about what the wife would do if she was required to give something, and she did have all of the medications and equipment in the home. Thankfully, they weren't required. So I made 6 phone calls to the patient's family in the last 48 hours of his life to really coordinate and make sure that this worked well. And then my last visit with him was a video conference where I pronounced his death virtually. The next slide. So pronouncement of death in the home really has long been a part of the care that clinicians provide to families at the time of death. It's our general normal practice, but pronouncement of death is not actually governed by any legislation in Ontario. So that means there is no legal definition of who is able to pronounce death, nor is there any legal requirement as to who has to do it. So in a position statement on managing expected death in the home during the COVID-19 pandemic, the Ontario Palliative Care Network said that virtual approaches to pronounce death may be considered where human resources are challenged to provide in-person pronouncement. Determining whether virtual pronouncement is appropriate will be based primarily on the needs of the family at the time of death, and planning for this should take place before death. So that's what we did. The patient's family was well aware that this was going to be the plan. She was comfortable with it. And yeah, again, was really, really part of the decision-making. The Ontario Medical Association has also made a virtual pronouncement of death process map to help clinicians with deciding whether or not this is appropriate. But unfortunately, they didn't provide any sample documentation of, really documenting what a virtual pronouncement looks like. On the next slide. So this is a copy of how I charted my virtual pronouncement. I was satisfied that the patient was in fact deceased. This is, all of the things that I looked for and exactly how it looks in his chart. So far, I have actually completed 2 virtual pronouncements of death since the start of the pandemic, and both were because of the pandemic. Things would not have gone that way otherwise. So the next slide is actually my last slide. So in conclusion to all of this, I hope you see that many aspects of palliative care can be provided virtually and done quite well. Virtual care has many strengths, but also some difficulties. It is not perfect for sure, but I can see a hybrid model of virtual versus in-person care continuing for me post-pandemic, whenever that is. The next slide is just some of the references for where I got all of my information. And then the last one here is contact. So that is it for me.
Great, Nikita. Thank you so much. Very informative.
Yeah, you're welcome. It's been an interesting year.
Yeah, it has. That is for sure. Okay, I think our plan was just to wait for comments and questions and discussion until after all 3 presenters have had the opportunity to present their material. So Nikita, we do have a couple of questions in the chat, but we'll just hold off until after Laura has had her opportunity here as well. So Laura McCormick has been a personal support worker for 15 years. with a career that is focused on supports for older adults in long-term care settings and on behavioral supports in dementia care. Driven by her passion for palliative and end-of-life care, she is pleased to be contributing her skills and knowledge within the home and community care team at Fort Frances Tribal Area Health Services team, where she works with Tribal Area Health to develop the palliative care program.
Thanks, Kathryn. Bonjour, everyone. My name is Laura McCormick, as Kathryn mentioned. I work for the Fort Frances Tribal Area Health Services with the Home and Community Care Program. I have dedicated my 15 years as a PSW to individuals who are at the end stages of their life. And my primary focus with home and community care is palliative care and palliative programming. I'm really honored to be here with you all today. Even though we're here together in this virtual environment, there's still a strong sense of togetherness. We share common goals and we're sharing knowledge, and therefore that really builds or really strengthens our networks of care within our communities and regions. So thank you all for coming. Next slide. Next slide.
Just trying to get this working. One moment, please.
Oh, that's okay. So while she's troubleshooting there, I'm just going to go over the vision, mission, and values statement at Fort Frances Tribal Area Health Services. Our vision is Minowayawan, which is good health. Our mission is we are the center of excellence and a leader in the innovative healthcare guided by the 7 grandfather teachings of the Anishinaabe, inspiring knowledge, strength, empowerment for the purpose of lifelong Minowayawan. Our values are wisdom, love, bravery, respect, humility, honesty, and truth. Next slide. So our program overview, our home and community care program operates as an outreach program to 9 First Nations communities. So just to give you some context of what that looks like in terms of distance, we cover an area that is approximately 340 kilometers. So when considering this area in which we support, it is fair to say that a considerable amount of our services is delivered on somewhat of a virtual level. And that can be for many reasons. The physical distance to get to a client when needs occur, maybe there's a rapid change in that client, and then also the need to support their caregivers when those needs arise. In our program, we work also closely with our health directors and any community health reps that are in those communities, and really any internal community support. So that could be PSWs, that could be some cultural supports. And on this slide here, you will see a list of some of the services that are provided. Next slide. So virtual palliative care defined. Difficult to define because everyone has a different idea of what that looks like depending on where you're located. So some it's those OTN capabilities, and for others it may be very limited. The support that we give our tribal communities can look a little different depending on each community. Some of these communities we actually access by the ice road in the winter, and some of our travel is down roads that are developed by logging companies. So these communities often tend to have poor cellular networks. Wi-Fi might be a challenge and isn't secure as other locations. And other communities, we have that option for FaceTime or video conferencing. And some clients, a landline is really the only means for connection. So really our ability to provide virtual palliative support is something that is explored on each individual level. And the plan for that support is reflective of their resources. And for some people, this isn't an acceptable platform for care, and that's okay. And that might be for many reasons. Maybe they have no family support, they have no resources available. And actually, as a result of the pandemic planning, we have increased our capacity to take on a virtual care pilot project. This pilot project is available on a pre-scheduled basis, and it's using an OTN's managed service model. We've rolled that out in 2 communities. However, we are still brainstorming ways how we could use it for virtual palliative support. Next slide. So initial visits. Initial visits are embedded in our process. That's the time where we're going to set that stage for virtual palliative care. So prior to this visit, a good question or a good habit that we use as healthcare providers is, what do I need for this visit? Do I have everything that my client requires when to enhance that virtual care down the road? Considering that you might not be able to see them again for some time. It might be a week, it might be 2 weeks, it might be 3 weeks, depending on what that home and community care schedule looks like. So basically, providing that home visit, we need to think that quality over quantity. Because the reality is that we need to be able to troubleshoot from a distance when those crises, big or small, arise. So trying to really set that stage for virtual care down the road. So it's important that the client and their identified caregivers are present for that initial visit, that in-home visit, just to kind of make sure that there's clear communication. And that's the spot or the moment that you're going to start that relationship and rapport building. And it gives everyone in that caring circle that opportunity to have their questions or their concerns addressed. And it's an opportunity for us as the healthcare provider to get a good sense of that client's environment. So maybe you're going to do a needs assessment. You're going to maybe take note of some safety concerns. You're hoping to be able to facilitate some conversations and determine some illness understanding. Maybe you're able to start that advanced care planning. Advanced care planning is an essential part of being able to provide virtual palliative care. It's really a formal way for clients to organize their thoughts and their wishes. And then from that we can use that as a guide, and really all of the caregivers can follow those advanced care planning wishes. And it really enables those next steps and develops some goals of care. So the in-home visits can also be an opportunity for us to connect with our palliative nurse practitioner, who is Nikita, for some care conferencing while in the home. And really from that home visit, we will leave with a collaborative support plan, and it will be implemented. And the client and their caregivers will understand the schedule, and they will participate in what their message or their most desired method of follow-up is. So slide number 6. So as mentioned earlier, palliative care happens in many different ways. It can be Zoom, it can be OTN, and it's obviously determined on what's available to those clients and those caregivers. The important thing is that client and caregiver knows how to contact their healthcare provider. So from that initial visit, we will, like I mentioned, we will have a plan, and the client and the caregivers can anticipate routine wellness checks. And so these are made for an opportunity for us to be able to assess how the client and the caregivers are managing at home, and whether changes need to be made to those care plans. So that could be a change of health status. Maybe that's a need for a nurse practitioner consult. Maybe we have to order some additional supplies or equipment, or maybe those wellness calls are a result of organizing some community supports within. And of course, needs arise outside of those scheduled wellness calls. The client would be encouraged to contact their healthcare provider whenever those issues arise. So you can understand the great deal of flexibility that is required, as clients' needs related to palliative care don't always happen between the hours of 8 to 4. And when caregivers and clients know that they have a backup plan, they know that they have that lifeline, they can contact their nurse, so they can contact their healthcare provider, they're more likely to remain calm, and those crises are diverted. Oftentimes our colleagues, my colleagues are responding after hours to phone calls, to texts, to emails, whatever that means of connection is virtually. And they're responding to those concerns to ensure that that support and the direction is given right at that time of need. And of course, knowing virtual limitations. There are times where a home visit is warranted, and for many reasons. Maybe the family isn't coping. We are not able to get a clear picture of what's going on in that home. There's some rapid changes. So these home visits, again, would be scheduled with the client and the caregiver. And they might even require nurse practitioner teleconferencing. And of course, the focus of those home visits would be to address those identified concerns. And the goals of those home visits would be to equip the caregivers with the necessary education and tools required to deliver that next level of care. So that might mean that at those home visits, we're leaving those step-by-step med instructions in the home. We're having the family or the caregivers demonstrate how to complete some of those physical care or the medications, just to ensure that they understand those step-by-step instructions and that they're comfortable. Maybe they are taking a video of that medication administration. Maybe we're walking them through some of the signs and symptoms and what to look for symptoms of discomfort. So it's really important that these teachings are left in a step-by-step and very clear manner, because as the next ingredient highlights, the families and caregivers play a vital role in our ability to deliver virtual care. As such, our relationship with them is key, and their comfort in delivering the hands-on care is one of our top priorities. So this comfort level needs to be followed up on, and really during the wellness calls, we are asking our caregivers, how are you doing? How are you managing? Are you comfortable? Are you taking care of you? Those sorts of things, so that we have a good understanding of what that looks like for those caregivers. Slide 7. So emotional support. A large portion of our virtual care is emotional support for both clients and caregivers. I just wanted to take a few seconds here to just share a story, a success story that has really stuck with me since my time at home and community care. To start off, our nurse case manager received a call from a daughter later in the day. It was after office hours, and the daughter's mom had just passed away. The family was at the bedside and they didn't know what to do. And our nurse could sense some panic in the daughter's voice. Our nurse was able to give some emotional support and reassurance to the family. She assured them that they could take their time with their mom and that there was no need to rush. They were concerned about some physical aspects with their mom, and the nurse was able to give them some simple instructions and address their concerns, and inform the family that there was no need to be alarmed and that this was a normal process. And as a result, this family was able to spend some quiet time, some intimate time as a family with their mom in their mom's desired space, without feeling scared or uncertain or stressed, all because they had that option for that quick telephone call with their nurse, of whom they had developed that trusting relationship. So that just always sticks with me. So number 6 on our ingredients is organizational support. It's huge. Fort Frances Tribal Area Health Services recognizes that delivering person-centered care, virtual palliative care, requires that employees be supported to be flexible in meeting their clients' individualized needs. So this support might look like flexing some schedules or compensation for their personal cell phones. And also organizational support in the form of debriefing. It's a huge element to staff self-care. Debriefing is important for staff to be able to get some stuff off their chest, or to be able to talk to their colleague and work some stuff out to get back on that frontline care. And of course, none of these ingredients already mentioned would be possible without the frontline healthcare providers who demonstrate a passion and commitment to delivering palliative care in this manner. It has been my experience that those who find themselves in this type of work possess these qualities. And of course, staff self-care. We have to know our limits, we have to know our boundaries, and we need to know when to reach out for help. So this might mean introducing a new nurse case manager, just so that you can take your much needed break. And then of course, to prioritize your own self-care activities. Slide 8. So benefits. There are many of them, and this list certainly isn't all of them. It's care happens at the right time and at the client's fingertips. Client and the caregiver don't have to wait until the next home visit. This fact alone can help prevent emergency room or hospitalizations. The care is seamless, as our home and community care staff are able to follow that client throughout their disease trajectory. It empowers family to be increasingly involved in the care of their loved one. We often hear as nurses and frontline staff that families say, I didn't know what to do. I felt helpless. So really empowering those families to support their loved one at these stages is just incredible. The care is intimate and private, and virtual palliative care removes a lot of barriers, especially for those individuals who live in remote locations. And it strengthens communities and builds capacity within our communities. Next slide. And challenges. Of course, we have to talk about them. They're a fact of life. But once we know them, we can figure out how to address them. Unfortunately, there is neither a one-size-fits-all approach to this type of care, nor the ways to address the challenges in delivery. Some of the challenges outlined here is technology. Technology is huge, maybe for many reasons. Maybe there's a lack of, maybe the person isn't able to know how to use it. Maybe the Wi-Fi services are poor. Some of our communities might not have cell service to reach out when those needs occur. And medical and professional language. We need to really be aware of how we're delivering the education to the clients and the caregivers. We need to really make sure that we're using those simplified step-by-step instructions, and having those family members kind of repeat that back to you so that you know that they understand. Communication can be a challenge for individuals who English isn't their first language. Then of course virtual care could be a challenge. And individuals who live with sensory impairments, this could affect both client and the caregiver. And it kind of makes that difficult for us to know or to get that whole picture of what that environment looks like. But for us, that sometimes is an opportunity for us to pull in our community supports, like our health directors or our CHRs or PSWs in the community, to help facilitate that virtual connection. And how to overcome those challenges that I just spoke to. So we want to recall our ingredients. We want to think, what ingredients are we using? Do we have enough organizational support? Do we have enough flexibility in our schedules? Just ways to adapt and to be flexible to overcome some of those challenges. The next slide. Looking ahead, so as I mentioned before, we have rolled out a pilot project, and we are exploring some ways on how that pilot project could support some virtual care capabilities. And also, just recently, we have increased our capacity to now have a transitional coordinator, and we're really excited about that, because that transitional coordinator, having her on board, it would really support those transitions in care to and from hospital, really enhancing that environment and making it seamless for our clients and the caregivers. Next slide. So a few takeaways: be flexible. Not a one-size-fits-all approach doesn't work. Every single situation will be different. And make your home visits count. Think of your home visits and the quality of them over the quantity. Your family and your caregivers play an integral role, so our relationship with them is a priority. Appreciate the benefits and embrace the challenges. Take care of your colleagues and take care of yourself, and always remember that your greatest resource is your heart. Miigwech. Thank you.
Thank you, Laura. That was great. Okay, and again, we will wait for any questions from to be addressed to Laura's presentation until after our next presentation. So our final presenter this morning is Felina Skye, who is a Dene Cree, originally from her homelands of Cold Lake First Nations of Treaty 6. She is a registered nurse for the past 22 years, working with the Treaty 3 and Treaty 9 region, who specializes in diabetes care, foot care, and whether that be education, services, or consulting. Felina has been heavily involved in home care nursing since 2003. Felina is also one of the board directors of the Northern Ontario Home and Community Care Network, and who is also the lead on this exciting new project she is about to present. Okay, thanks, Felina.
Thank you, Kathryn. You can hear me well?
Yes, we're good.
Okay, great. So miigwech, and thank you for having me on the call this morning. I'm honored to present this presentation, and just a little background information about the Northern Ontario Home and Community Care Network. We're a fairly new association incorporated in mid-2018. We started off with 3 board members. We now have 6. And the network covers about 75 First Nation communities that have home and community care programs. And I say 75 because we're not sure if it's 74 or 75 right now. We're still figuring that out. But just know that in the first year and a half or so with the network, it was really slow moving and slow going, getting ourselves organized. And then we were working on a conference, and then COVID happened, and so we spun off into in a different way with our launch. So we're just in the process of really establishing this new network. And so next slide. So just, and this network here has, it really does address all of the home and community care issues that we often face as home care staff, and palliative care being one of them. And at that time when COVID began and, the world started to shut down and we went into virtual care mode, we had to, postpone our conference, and we sat together and said, okay, well, how can we help? How can we help our home and community care programs? And one of the things that was, very apparent in First Nation communities is that they, didn't have really an understanding of what virtual care was and how to go about providing that change that was required. Although there's like OTN in some communities, there was still, within the home care sector, a very, not a very good understanding of how to go about this. Next slide. So at the end of, next slide. Oh, so at the end, oh, sorry. Back up one slide. So at the end of May, that's when that meeting occurred, and the network decided that we were going to be, some assistance in this area, even though we really didn't know what we were doing, to be honest with you. None of us are tech people or anything like that. We just saw a need and decided that, this is the area that we think the network should go to and help. So over the period of the last 10 months or so, we've had a series of weekly meetings with all kinds of organization partners to gain, their knowledge and expertise on how we can, pull off this type of pilot project. And we're just so grateful for all of their input and the time and effort they've put into the virtual care project to help this process along. And so here's a list of our organization partners, and I'm not going to say it's an all-inclusive list, because, we never know next week if we're going to add another partner on who's going to add to the piece of the puzzle here. But you'll also see that we have not only funders, partnerships, but also education institutes, tribal councils, and at the bottom there, you'll see that we have our community partners that are also a part of this project. Next slide. Going into the project, we knew there was going to be some severe challenges that we were going to have to face, and a lot of this was already discussed in the previous presentations around capacity, technical infrastructure, whether there was connectivity or not, you know, the sustainability and funding of the project, and just even looking at, you know, how can we make sure that this is a community engaged approach, and that we are driven by our Indigenous perspectives as well within this project. And of course, partnerships and alignments of all of the people at the table, and timeline, knowing that we'd be running on tight timelines. Next slide. And so really the purpose of the project, and we say it was a small scale when we started, but now it just feels really gigantic. It'll contribute to the development of processes, resources, and sustainability for virtual care management at the frontline level of home and community care programs. And so initially we had looked at just adding on 2 First Nation communities, but we have since then grown that. Next slide. And here's just a list of the different activities that are involved in this pilot project. Like I said, we've been spending the last 10, 11 months here in partnership activities with numerous meetings. We've also had the opportunities to customize virtual care training for home and community care staff. And, you know, we're still doing some ongoing work around the development of virtual care platform, training on how that should look. And, you know, a big piece of this is, you know, where are the policies and procedure and the development of that, and how we are to, you know, be a resource for home and community care programs to be able to access those things. And obviously technical support that, you know, a lot of us at the network don't have. So, you know, very, very grateful for those partnerships that add to that piece here. And then also looking at the evaluation processes, ensuring that, you know, what we are delivering, or what we will be delivering, is meeting the needs, and what else needs to be done afterwards. Next slide. Oh, sorry, you're there. So just before I speak to this slide here, I just wanted to explain that within this pilot project, it's very, you know, it's not clearly set out as in terms of, you know, we had an idea at the beginning and this is where we're going to go with it. And the basis of this project was based on community pace and Indigenous perspectives. And so that's what really we wanted to make sure that we highlighted within this project, that kind of sets us apart from other projects that are going on, that, you know, that we are ensuring that the community's voice is heard through this process, and what's best and what's going to work for them. And, you know, also while trying to increase this digital access to healthcare at a community level when we're not able to see them face to face. And it's not just during COVID pandemic times. It could also be like when there's problems with travel, the client can't get an escort, or, you know, they're not feeling, you know, maybe well enough to take a flight into the local hospital and all those kind of things. So, and then also, you know, to support the communities in general of a virtual care program, and to work towards the development of a virtual care toolkit for these programs. So programs are not floundering out there, and they have somewhere to go to find all the areas of expertise that they need to develop this in their home communities, because we can't get to the higher level types of virtual care until we have that ground level work completed. and then of course our outcomes will always, go back to our government and show the need as to the reason why we need these kind of projects off the ground to help increase that access for our First Nation clientele in home and community care. Next slide. And I know I'm probably talking really fast, but at the end of the day with this project here, we just want to make sure that we're giving the support at a community level, but we can't get to that support at a community level unless we have some of the higher level activities put in place for communities to be able to lean up against. So that's why I say that this is just the groundwork, like just the foundational work to increase that digital capacity for clients that receive home care. And, to try and cover some of those gaps in services during this time is really important as well. And again, that, we as a network are always looking for creative solutions to our home care programs to, access the services that they need at the time that they need it. And I'm just really grateful and appreciate to be a part of this process. And that now with the, virtual care being a big part of all of our healthcare world, I'm glad that the network was able to also see this vision and, help move forward some of this work because I just really feel that later on, we don't know what virtual care is going to look like. Maybe someday we would like to see patient remote monitoring or, virtual robotics and those kind of things happening in our communities so that we can have the best access to care as possible in community as well. And keeping in mind that, in order to be able to deliver palliative care needs as well virtually, a lot of this foundational work needs to be initiated in community and shared amongst the First Nation communities. And yeah, so that's pretty much the virtual care project in a nutshell. And I just would like to raise a little shout out to Fort Frances Tribal Area Health Services, as they are also a part of this virtual care project that we've been working on. So I really did appreciate their presentation. Miigwech.
Hey, thank you, Felina. That's great, exciting stuff. Lots of opportunities to come out of these crazy pandemic times.
Yeah, thank you all very much. Thank you, Kathryn. So we have about 15 minutes for some Q&A and discussion, which is great. We did have a couple questions come in early and from Robin Sano. I think they were for you, Nikita. So the first one was, do you think that the leap to using virtual care was a bit easier for you because you work so remotely in the North on a regular day pre-pandemic?
Yes, it was a pretty easy move for me. I'm also comfortable with the technology. Yeah, it was quite an easy switch.
That helps. And Robin also asked, have you been able to successfully do video visits or provide virtual care in any of the First Nations in your catchment area since the pandemic began?
Phone, yes. Video, no. I've actually had a few patients on different reserves, and yeah, I haven't been able to successfully connect with anyone over video, either because of a lack of the physical equipment or the internet or cell signal. But I am still doing phone calls with people on reserve.
Great. We had quite a number of thank yous. Jill said, thank you, Nikita. Really great cases that you shared. Thanks for sharing the virtual pronouncement, which was definitely an interesting.
It was interesting. It was. They both were very interesting.
And more thank yous. And Hillary said, awesome to see all the partnerships being developed. Lots of opportunities for collaboration, for sure. And Cynthia asked, is MAID, well, it's flipping around here, is MAID in the North widely accepted, or is this a new concept?
It depends on the community. So there are MAID providers and assessors scattered throughout the North. You know, I can't say if it's widely accepted or not. It depends on where you are. But it's definitely happening in both home and hospital settings.
Hillary asked, have any of you been able to help facilitate a virtual consult for a patient at home to connect with their specialist in Thunder Bay or another urban center?
I haven't.
No.
Not that I can think of either.
Oh, Robin said, I have, from Thunder Bay to a neurologist in London in the patient's home. Interesting. Are there any other questions? Can we prompt anyone to come off mute? And
I am just going to make a comment about the help facilitate a virtual consult. We have done that actually. We have supported some of our clients with having those meetings with their specialists in Thunder Bay. Sorry, I forgot about that. And it's more just like to help them understand what maybe that meeting is all about, right?
So I was just curious, for Nikita, are you finding that you think your patients are preferring the virtual care over in person? And is that more so because of COVID concerns, or?
Yeah, it varies. I think they have their own COVID concerns and then are happy to, limit their exposure. Yeah, I'm not sure if they would prefer one way over the other given, no COVID, but I guess that's why that one study in the States was happening, to see if the care actually is equal. I really do think it is, and people are definitely happy that I'm so available.
Yeah, it sounds like you're definitely making more connections.
I am, yeah. And we've had a lot more deaths at home since the pandemic because people don't want to go into hospital. And I don't know that I would be able to continue to provide the same level of care given the increased workload if I was continuing to travel as much as I did before.
Right. And Hannah Albany asks, what impact has providing virtual palliative care on caregivers and their role in the palliative care team? Or what impact has providing virtual palliative care had on caregivers and their role?
I'm not sure I fully understand her question.
Well, are you finding, is it even more kind of pressure on caregivers since they would have such a big role, I imagine?
Yeah, I mean, they have a big role anyways, because nursing in a home care environment isn't 24/7, like physically there, right? The nurses come and go. So to do a death at home involves a huge involvement from the family, and the nurses are providing face-to-face visits. So I don't think having me be virtual has changed anything.
Okay. Robin, do you find families open up more about their concerns over a virtual connection versus in person? Like, are they more forthcoming about issues, or has there not been enough time to assess or reflect on that?
Seems the same.
Sorry.
Go ahead, Laura.
I think that when you're on the phone with a caregiver, I think that they tend to open up a little bit more. Maybe they can find a private spot in their home to talk to you. I find that caregivers have that opportunity to be emotional on the phone with you versus where if you're in there in person, maybe they don't want to cry in front of you. So I think that virtual connection really helps the caregivers. or they can text if they can't talk.
Not any worse. I still have really good conversations with people over the phone or virtually. I'm pushy and ask a lot of questions, so I don't let people get away with not opening up about their issues, and that happens in person or virtually. So I think, yeah, it's equally as effective.
And I was wondering though, it sounds like you kind of have to be on like all the time when you're talking about texts and all that kind of stuff and after hours. And I know, Laura, you really talked about the importance of self-care, but it seems like, yeah, it must be challenging. And we had a question for Nikita. Do you feel or get a sense that the dying at home trend will continue after COVID restrictions lift?
So it's really well documented that people prefer to die at home. And that's been for years. People have listed their preferred place at home or preferred place of death being at home overwhelmingly. I don't know if it'll continue or not, because the main reason why people are like anti-hospital right now is because of visitor restrictions. So I don't know if that same push by the family to step up and really take on more care than perhaps they want to will still be there if the easy option of the hospital is available again. So we'll see, but there's way more now, way more at-home deaths than there were normally.
It'll be so interesting. A lot of research to be done.
Sure.
And Robin had another question. In general, Laura and Nikita, do you think more people have had more access in general to good end-of-life care now that virtual care is acceptable by patients due to the pandemic?
Trick question there, Robin. I was here before and you were managing me, so I always did excellent care. I do have more referrals now because people want to die at home more, which gives them more access to me. But I also work with an excellent group of hospitalist physicians that I personally have LEAP trained. So I think that they would continue to provide this excellent care in hospital, even if I personally wasn't doing it.
Yeah, I think that, I mean, going back to like, looking at Nikita's contacts and say a 25-day period and being able to have that number of contacts by a palliative nurse practitioner. I mean, that's incredible.
Yeah, and before they would have got lots, but maybe not that many.
Yeah. I mean, I think that, I mean, yeah, I think that I think that virtual care brings better access, right? You're not waiting in a emergency room. You're not waiting 3 weeks for your next doctor's appointment. So yeah, I think that having that care at your fingertips definitely is more access in general.
So I know, Nikita, you had said that currently it's people that kind of have access to their own devices. So I guess I'm just curious, and maybe it's a silly question, what people do that don't have access to devices. Do you still you'll still go into the home if they need you? And
everybody has a phone, so I haven't had it come up where I couldn't contact someone over the phone. Yeah, I am still doing some in-person visits for specific things when people need a physical exam. Yeah, that would help change the treatment plan. Depending on how the pandemic ebbs and flows, there are times when I will go in for my initial assessment when I can, because, you know, things are pretty good. And then when everything gets locked down again, I tend to switch myself back to more, virtual. Yeah, but everybody, at least that I've talked to, has a phone at least.
yeah, and a key word that stuck out for me is really flexibility. I think that's a big piece. Yeah. Anyone have any final thoughts, questions for our speakers? Well, I'd just like to thank you all for being here on behalf of Sarah and also the Northwest Regional Palliative Care Program and our Palliative Care Education Collaborative members as well. I was going to launch just a quick evaluation poll, if you don't mind completing that for us before you leave. And also, I'm just going to post the link to register for our next session. Hopefully you all will join us for that one as well around COVID-19 and compassion fatigue, self-care for healthcare.
Oh, you're muted, Steph.
I am muted. So I'm just going to launch a quick evaluation poll here and post the registration link for our next community of practice session in the chat box. That one's coming up on March 11th with Kathy Cordes Miller, and it's going to be focused on COVID-19 and compassion fatigue, self-care for healthcare providers. So we hope you'll all join us for that session as well.
Note, there has been another question.
Yeah, I just saw Cynthia has a MAID specific question.
Sure.
With a client in her 40s with breast cancer and a request for MAID, is there a waiting period from the client request to the acceptance of her request? So 10 days in Ontario. Yes, so there is a built-in waiting period, but there are two reasons why the waiting period can be waived. One is an imminent risk of natural death. The other is an imminent risk of loss of capacity. I believe this patient was pretty close to her 10-day wait period anyways. I think she was scheduled like to have MAID 2 or 3 days later. But at a 10% PPS, I mean, if we didn't provide her with MAID, she would have died naturally that day, just not in the manner that she requested. So yes, that can, there are exceptions.
Thanks, Nikita. So we hope we see you all at our next session. And as a reminder, I will follow up with some additional resources through email as well. So until then, take care, everybody. And thanks again for joining us.
Thanks. Bye, everyone.